So we're here to just continue discussing one more salient point from the work of Dinnar, D-I-N-N-A-R, and as with the previous videos, I will make sure that access to that study is available, or access to that research is available by linking to it. One of the things that was noted, along with the fact that multiple osteopathic practitioners, or the same osteopathic practitioner, really would use different tests for the same problem, right? So if they were looking at the lumbar region, instead of using the same tests all the time to assess the lumbar region, they would use different tests between different patients, or even different tests on the same patient. And we've discussed why that may, although it's a hallmark, it may be a bit of a problem in so far as reproducibility, so the ability to actually have multiple people agree on it, so inter-rater reliability, as well as, I did it this way, I'm checking another person, what are the similar features? So if you use a different testing process, you start to misinterpret similar features. You may not even catch them because you're using different tests. However, the variability is useful, especially when you are not able to do the desired test on a patient. So the ability to, in a novel situation, use a different test to test the same motion is important. So both skills are important. Having a consistent assessment process, a consistent assessment algorithm, as well as the ability to be novel in your approach, both have their place. But one of the other salient points, or the other salient point that I'd like to discuss, is that when observing the manual practitioners, the osteopathic physicians from America, but they were actually OMM people, they were doing the hands-on work, the salient feature that was noted was it was very difficult when attempting to classify assessment processes. It was very difficult to identify the difference between assessment and treatment, right? So something as simple as a straight leg raise. So somebody's attempting to test the posterior chain through the leg, or at least tension, and you can speak about multiple layers of tissue. You can talk about the hamstrings, you can talk about the glutes, you can talk about the gastrocsoleus complex, you can talk about fascia. Regardless of which of these structures you attempt to speak about, all are likely involved, especially when you do something such as a straight leg raise. So if I do a straight leg raise, right, and I find tension here, well, I can very simply stay, and if I hold, that becomes myofascial release. If I have the patient pushed down, well, PIR, RI, muscle energy, whatever you'd like to call it, but patient active approach, so the patient actively contracts. And then if I start to come up and down, right, some people are rhythmic in their assessment approach, but going from this to holding, to having the patient push, to having rhythmicity, to having something different, it's very difficult for an observer to see the difference between assessment and treatment. Now, I'd like to speak about the fact that if it's a hallmark that's observable in multiple different practitioners, there may be something to that as far as transmitting the ability to apply treatment appropriate to what was found. So if I go ahead and I do a straight leg raise, and I believe that the hamstrings are a bit of a problem, or I believe that the posterior chain's a problem, if I continue to use the assessment method and hold on to it, or have the patient become active, or create some rhythmic approaches, so a rhythmic motion, what some people would call it articulation, regardless of what I do, the point being I can use the same method, I can treat what I found where I found it, right? So, or for more clarity, if I believe that this is the hamstring giving me a problem with my straight leg raise, well, I can go in and do some soft tissue work to the hamstring itself, right? Pull across, right? I can start to work on the hamstring itself, and then I can retest. This would be clear if I did a straight leg raise, right? For my test, I do my treatment to the hamstring specifically in an attempt to see if it was a hamstring. So what I'm doing at the point of changing my approach, so changing my treatment from the assessment approach to a slightly visually different treatment approach, an external observer would better understand that I was changing them. That being said, a very simple way, if you are wondering what to do as an osteopathic practitioner or a hands-on practitioner about the problem that you found, be you a massage therapist or an athletic therapist and you perform an orthopedic test, or a motion test in general, be it orthopedic or otherwise, and you identify a motion problem, well, you can use that test to become the treatment, right? That is a consistent hallmark that is observable between osteopathic practitioners. The test becomes the treatment just in how they are using the motion, right? So as I said, straight leg raise, and then you hold on to it, you wait, you have the patient become active. Whatever you do, that's switching assessment into treatment. This was identified, or at least described as early as I'm able to identify, by the work of Dinar in 1980. So what he saw was consistently practitioners would perform what seemed to be a test, and then they would just keep doing the same thing. That became the treatment. And then if you do the same thing over again, it's a fully integrated motion. The same motion is the assessment, the treatment, and the reassessment. For an external observer, it's easier to identify when the test looks one way, the treatment looks another way, and then the retest looks the same. If the retest looks different, they don't know you retested. That may also be valuable in that if an external observer who's trying to figure out what you're doing can't tell when you're retesting, then the patient probably can't either. So for the sake of the patient and for clarity for the patient, it would be advantageous to perform your test, identify that you performed your test. Oh, hey, that's not moving so good. Perform a treatment, whether it's the same motion as the test or not, perform the treatment, then retest the same way you did the first time so that yourself and the patient have clarity. This is the same, aka it did not work the way we intended, or this is different, it worked the way we intended. Something else that you may see, there's quite a few practitioners that seem to appreciate a leg rotation, right? So my hand at the moment is touching the lumbar spinous processes. I raise up, I assess what is or is not happening to those lumbar spinous processes. If they're not falling into my hand, then I believe that somewhere between the knee and the lumbar column, there's some form of restriction that is giving me a problem with creating lumbar flexion, aka in this motion, the lumbars prefer to stay extended in this united motion. That was my assessment. My treatment simply kind of starts to do this. My reassessment looks exactly the same. It looks exactly the same. So you can move seamlessly with the same motion from assessment to treatment to reassessment. However, when you change the assessment or the retest, the reassessment, there's a lack of clarity not only for yourself, for the patient as well, because testing in different ways, as we showed in the previous video, if you test something one way to start and you test it a different way, those tests are different. Although they induce the same motion, they are different tests. So again, the whole point here is to identify that it is observable that between osteopathic practitioners, assessment and treatment are very difficult to observe the difference between, because the movements are often exactly the same. That's fine, you just have to be clear that that's what you're doing.